This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
Hello, everyone. My name is Bjorn Egeland. I'm your host today at the 1 Million Live podcast from Laerdal. And with me today, I have Professor Scalese, who is Director of Educational Technology and Development at the Gordon Center at the University of Miami in Miami. Before we start, Ross, tell me a little about the Gordon Center. What's that all about?
Well, the Gordon Center is a center of excellence of the University of Miami and its Miller School of Medicine. It was founded by Dr. Michael Gordon, renowned cardiologist and medical educator, more than 40 years ago. A major part of the work of our center has been simulation and technology-enhanced medical education. And our mission is saving lives through simulation technology. We hope that by improving the methods that we train our learners, they will take better care of patients and improve patient outcomes in the future.
Sound great. So you are a very important person for us to talk to, because what I wanted to talk to you about today was a bit about simulation and using simulation as an educational tool, and a bit why. And when we come to why, we also, touch into research and, is there any proof that it actually works, and et cetera, et cetera. We have been doing simulation in the medical world for a long time. In other fields in the world, they've done it longer. But any thoughts about the idea that it works or doesn't work, or what it takes for it to work?
Well, you're absolutely right. There have been professions that have been doing it longer. Aviation would be one of the classic examples, I believe, but also nuclear power plant operations. The military for quite a long time has used various forms of simulation for preparation of their war fighters and so forth. We try to take the best lessons learned from those other professions. And it's really been, I would say, in the past couple of decades, since the very early 2000s, that we have seen simulation increasing in use dramatically for health professions education. And over that time, naturally, people have asked, well, is there any evidence that this works? Many simulation modalities can be expensive. And in terms of, investing in those technologies for educational purposes, people are right to ask, before we sink our money into a new simulation program, is there evidence that it works? To answer those questions, research has been ongoing for quite a bit of time. The Gordon Center, because we've been around, as I said, predating the rapid expansion in the use of simulation, we have done quite a bit of that work here. In fact, our original name was the Gordon Center for Research in Medical Education, not exclusively in simulation, but a large part of our work was in that area. And more than 15 years ago now, we published a systematic review that looked at the uses of simulation and its effectiveness. In terms of research that could answer those questions that you're asking, I think there are different types of research that we could talk about. George Bordage and Dave Cook proposed a model where there are three large areas of research that one could do. The first is descriptive research. And that's probably most appropriate when an innovation is new. Early on, when people were just describing the early uses of simulation for health professions education, that's a lot of what you read in the literature. Case reports, descriptive type of studies. But then the next area of research is justification research, answering the main question that you posed, which is, does it work? And then once things have been more well established, and I think there is ample evidence that simulation is effective, but then it's, what are the circumstances under which it's going to be most effective? That area of research is what we would refer to as clarification research, not answering the does it work question, but the details of with what population, under what circumstances, when, how. That is kind of where we are at now, I think, in our research agenda in simulation for health professions education. The systematic review that I talked about actually focused more at those clarification type of questions. A collaboration known as the BEME collaboration, which stands for Best Evidence Medical Education. This group formed in the early 2000s, pretty much synchronous with the increase in use of simulation. And they were, like the evidence-based medicine movement on the clinical side of health professions, they were looking for an evidence-based, not just descriptive reports, but actual experiments that showed that some of these educational interventions were working. And they came to the Gordon Center to lead this systematic review because we had a long history in simulation. And they didn't pose the question, does simulation work, or is it better or worse than, say, traditional forms of health professions education? They asked, given that so many places are adopting these methods, what are the features or the uses that lead to effective learning? It's quite a different question, and it was smart on their part, because you can know that in certain hands, simulation may be great. In other hands, it might not be as effective as someone who is just a terrific lecturer or a terrific bedside teacher, more of the traditional ways that we used to learn in the health professions. So in our review, we specifically looked for reports that documented that some learning had happened. Okay, so we, by necessity, this was looking at positive research, where the positive results, and then we delved into, in an iterative fashion, what are the features that they talk about in these reports that seem to contribute to the fact that learning did take place. And we identified and listed the top 10 most commonly cited features. Some of them will come to no surprise to the listeners of this podcast, I think. The number one most cited thing was you had to provide feedback to your learners, right? That's common across all educational modalities, I think. The fact that it has to be integrated into a curriculum. It can't be one-off. Hey, just check out this simulator. It's really cool, and then you expect that it's automatically going to work. No, it has to be a required part of training. You have to give learners opportunities for repetitive practice of skills. We had to control the environment. That's one of the real benefits of simulation, I think, compared to our traditional methods. In the clinical world, things get messy and you can't control what's happening on a given day in the hospital wards or in the outpatient clinics. In simulation, we can control that environment and make it learner-centered and so forth. So we can provide, as a sidelight, the reference to that BEME systematic review that enumerates these features. And then in subsequent work, we've fleshed those out and added a bit to the list as more and more research has been done. But even then, we published that report in 2005, and we had over 100 articles, close to 110 articles, that demonstrated effectiveness. So right there, in terms of the justification research, you can see that there is already a large corpus of research that supports the idea that it does work. But what's more important is that you implement those evidence-based features that are going to make it the most effective. We've had people come back to us and say, oh, we tried doing that, replicating that study that you did, and we didn't see the same results that you did. Or, another research group, some of the work that they have done, when it can't be replicated, it's that sometimes they missed those key features of the implementation. It wasn't a fault with the simulation per se. It's just the way that it was put into practice.
And of course, you mentioned it yourself. It is not, you said the modality or, the things like you don't really, it depends what you want to simulate. If you have a group of people that needs to learn to work together, without having, too many bosses at the same time, you could have a simulation session, I assume, where you train on managing like a trauma patient, but you don't really need that patient for that. You could have like a broomstick in a bed because, it is the communication which is the focus.
Exactly.
And also it's quite interesting because, people who are interested in simulation per se, they might be very interested in the simulator, but they might not really understand that it is just one of several learning elements or teaching elements that is available. And as you said yourself, one of them is a lecture. A second one is the book today. Third one is, the internet, whatever. And the fourth is simulation. And sometimes one of them are more important than the others, depending on what we're talking about.
Absolutely. Yeah. Again, the traditional formats of large group, largely passive learning methods were reasonable at imparting knowledge, right? But that only gets you so far, especially in our very hands-on type of profession that healthcare is. The skills part, you really have to do. And so active forms of learning like simulation are going to be much better matched to those learning outcomes that you're trying to achieve. You also alluded to the fact that, early on, a lot of the work that was done with simulation focused around individual psychomotor skills. So can a given doctor or nurse or technician, start an IV or intubate a patient, be able to do certain kind of individual skills. More recently, though, we're realizing that in actual healthcare settings, sure, there are individual practitioners, but the holistic care of patients comes down to the team approach. And so team skills have emerged as a very important area of research within simulation-based education. Again, looking to other professions, like in aviation, and adopting some of those same models, right? It used to be called cockpit research, resource management, CRM in the aviation setting, was adapted decades ago in anesthesia to manage emergencies in the operating room, just like they might do emergencies, in the in-flight setting. And so they changed that to crisis research, resource management. And that has expanded not only, it started with the anesthesiologists, but then emergency medicine physicians, critical care, because obviously high risk settings like those where acute care takes place, trauma settings, as you mentioned, those are where those team skills really get emphasized when things are time critical and so forth.
This is a podcast from Laerdal Medical.
We have different settings, of course, where this tool, this way of learning is very useful. One is, of course, in university in a pure, student situation. But another one is, of course, also in a clinical setting, like, for instance, like an ER, emergency room, where, the ambulances will arrive with patients, and many times you don't really know what you're going to get, but, still have to manage it. You also talked about this. We start to have quite a long history and to build on when it comes to understanding the simulation as a learning and training tool. But in reality, we often see that the doctor or nurse who is responsible, sometimes also the paramedic, who is responsible for overseeing the continuous education and maintenance of knowledge and experience at the ward, they are new. They stay in their job for 2, 3, 4, maybe even 5 years, and then new people come in. And of course, because of it's a cost involved, very often there is no time for any handover. One leave, another one comes a few weeks later and has to start to relearn the whole thing. When you have a situation when there is a relatively new person who is responsible for looking into this, and there is a manager who doesn't really understand the value of taking time off to use simulation and see the benefit with it. Can you give some advice how they can build a case?
Well, again, getting in some of your comments there were making me think of, again, those clarification or those who, what, where, when, how type of questions, right? Efficiency of learning is another aspect, right, that can become quite important and relevant in workplace-based settings, right, where they may not have the time to go off and do a dedicated course of some length. That would require backfilling on the wards and so forth. We encountered this quite a bit at the Gordon Center. A very large number of our learner population are pre-hospital personnel, so paramedic, firefighters, even some law enforcement folks who are, busy working, in the pre-hospital setting. If they come to our center for training, then someone has to still be manning, the fire station and so forth. So efficiency of training is another one of those aspects that we can look at. There are certain ways that you can overcome some of those benefits. Blended learning methods are becoming more and more popular. So that, for example, the things that are the cognitive components, learning, the algorithms, some of the knowledge piece, they don't have to come and sit in a lecture. Half of a training day used to be sitting there watching slides, right, and being lectured at. That's not only less effective learning because it tends to be more passive, but it's not very time efficient when people might do that in advance on their own. And so more and more you're seeing simulation programs around resuscitation. We've been implementing that for some of our courses here at the Gordon Center too. For example, first responders to strokes and certain other time critical elements. We've now condensed our courses from being, a couple of days down to 1 day, and now even only a partial day, where we front load the cognitive material with e-learning programs that they can do at home on their own pace. We try to have them to be adaptive learning so that it's individualized to the specific learner. And then they only have to come in for the hands-on part that you really cannot reproduce by having them read a learner's manual or watch an e-learning program on their computers at home. Hands-on stuff, really, you have to practice those skills. So that's how we spend their time when they actually come in. And that's where using then various forms of simulation like mannequins and things like that can be, task trainers and so forth, can be very effective. So there's the time efficiency piece, and there's ways that you can design your curricula to accommodate busy practitioners. The other thing is you don't have to make them come to you in the simulation center. More and more, we're doing what is called in situ or in situ simulation, meaning it's in the situation in which they actually work. So we bring the mannequins to them. We will set up in the trauma bay of the emergency department or in an ICU bed in the actual intensive care unit in the hospital, a mannequin, and we will call a code blue or some other urgent situation. Here's a patient that just came in, and we will ask them to act as if they would in the real situation. In terms of their buy-in into the simulation, it can be much higher in the in situ setting, right? Because this is going to be using the actual equipment that they're used to using in their day-to-day practices, right? One of the ways that you can kind of lose your learner is if in your simulation center, you don't have the defibrillator that they normally use. You don't have the particular equipment that they normally use. And then you kind of lose them when they say, oh, if this was my XYZ machine, I would have done it properly. So you can obviate some of those potential problems with the fidelity or the realism of your simulation because you bring it right to the actual environment. The other thing that's very powerful with in situ simulation is not only do you uncover individual skill deficits, and you can try to improve those, you also can look at the team functioning, but then you get, very importantly, aspects of the systems, which are often implicated when patient errors happen, when medical errors happen and patient safety is compromised. It's often not because the individuals didn't know what to do. It's because there was some breakdown in the system of care. And sometimes those things can only be uncovered when you carry out your training in the actual environments in which they're practicing.
We have seen many times, at medical schools, nurse schools, paramedic schools, where they have team training and someone plays the role of a nurse who's actually a medical student, or as a doctor, and he or she is actually a paramedic. And you compare this with getting the real people in to play their own role, so that, because, it doesn't really make sense in many ways to have people playing someone else than who they are.
Yeah, that is a threat to the validity and the fidelity of the simulations, and that can have negative impacts in terms on the learning that happens. Of course, so in situ sounds like a great idea. Of course, in theory, then there are also the practical challenges, though, of the implementation, right? Is there an actual open bed in the ICU that I can come in and do my training on? Or, even though we plan these things, we try to choose a day, for example, where the OR schedule is particularly light if we want to do something in an operating room. But you still never know in the real clinical situation. Some emergency might happen right then, a real emergency, which will take all of your potential learners away to actually do their jobs. So in situ, again, it can be a very powerful form of simulation-based learning. But you're always balancing that with the practical implementation things. It's very key to have buy-in. We have quite a successful in situ simulation program that we run at our hospitals here at the University of Miami Medical Center. But that has taken buy-in from senior leadership, not just the physician leadership, but actually usually more importantly is the nursing leadership, because they really have their finger on the pulse of what's happening day to day on the wards in the various specialty units and so forth. And so the implementation in our system has actually been driven by nursing leadership, and that's been a very important part of that program here for us. You have to get stakeholder buy-in, obviously, to be able to implement and have a successful any of these programs. Which maybe circles back to your original question then, is how do you persuade them, right?
Absolutely.
And so again, you can present them with evidence. Sometimes you have to do the experiments in your own setting to show that it is relevant there. Then there's all the inevitable question that somebody in the totem pole is going to ask too is, how do we pay for all of this stuff? Because it is still time away from work. For example, even if they don't have to travel far to go to do this training. So the return on investment question, cost effectiveness is often asked as a question. And there have been published reports that have shown even that level of impact, that simulation can be quite cost effective. There were a series of experiments done by colleagues of ours at Northwestern University in Chicago, really elegant series of things that not only demonstrated that simulation worked, that it changed practitioner behaviors in the real world setting. For example, related to code blues, it showed that simulation-based training of internal medicine residents improved their adherence to the published American Heart Association algorithms on how you should conduct these resuscitations. In other settings, for example, in central line placement, they showed that improved patient outcomes. They used internal controls with different ICUs, where they had trained the medicine residents with simulation to put in central venous catheters. But the surgical residents rotating in the surgical ICU had not had that training. This was a very clever study design in that they tried to control, to the extent possible, for internal things that might happen, right? So if you compare different facilities, for example, different institutions, well, they might have something systemic that makes them have better outcomes. Like they use antibiotic-coated catheters in one place, but not in the other. Well, by doing this experiment within one hospital, just in different ICUs, they tended to control for some of those other systems things. They should have been the same. If they made new purchasing decisions, for example, on equipment, that would affect all of the ICUs. So the only difference that we could really point to is the difference in training. And they showed that they had significant reductions in catheter-related bloodstream infections. A little bit more, just that last example about the catheter-related bloodstream infections is that they did later calculation of the cost savings, right? Because if a patient had an infection that kept them in the ICU or in the hospital for additional time, in the United States, actually, that is not reimbursed by our public health systems of payment. So they calculated the costs of the training program versus the added expense of those additional hospital days and the treatment for these patients with nosocomial infections. And they showed it was at least a 7-fold return on investment. And the reason I say at least is because they factored into the cost of the training, the cost for the mannequin that they used. And that's a one-time cost, right? So in subsequent years of training, they're not going to incur that full amount every time. So it was a significant cost savings. And to show that once they showed that return on investment to the administration of their hospital, they were able to get funding for a lot of their subsequent simulation-based training. So again, even the cost effectiveness piece, that has been answered in certain cases. And I think you can make a very powerful argument in favor of using simulation for your educational programs.
This is, we could talk about this for hours, Ross, but the time is up, actually. So I want to thank you for spending a little time with us here. We will add some links on our landing page to some of the research papers which was referenced here. And I will invite you all to go in there and have a look at it. I think it's going to be very inspirational. And thank you very much again, Ross, for spending time with us.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.